want to thank everybody who has joined us for the 2020 annual NEMSIS V3 implementation meeting. We didn't so much expect that we would be doing this as of Zoom at the beginning of this year, but very grateful that we have the opportunity to be able to meet with you and really continue this important meeting that's held on an annual basis. We'll just remind you folks who have had the opportunity of being with us in the past, this is a very communicative meeting, an opportunity for really the software vendor companies and the states who are represented by all of you have the opportunity to share with us successes or failures, other weaknesses that we've experienced as the NEMSIS information system this past year. How can we improve things? How can we make things better? This really is that opportunity for us to look, take a hard look at what we've accomplished this last year, what things we can improve on the next year. It really is the purpose of this meeting. This is day one of a 3-day meeting. We'll spend 4 hours together today and 4 hours on Wednesday and Thursday. So we will hope that you'll be as interactive as possible. We recognize that in this type of an agenda and this type of a meeting environment, you have competing interests and folks who need your time. We've built in lots of breaks and incentives for you to come back and join us in the meeting. So hopefully we can have your attention for the time that we have together. We'll be spending a lot of time in breakout rooms, and so be prepared to be able to share your opinion. You'll be in groups of 10, and you'll be in a different group each day, but we'll stay with that group for the day. So you'll have an opportunity to meet new folks and to share your opinions with others. The agenda is here. You've all received this in association with your invitation to the meeting today. Julianne's also put a link to the agenda in the chat, so you have the opportunity to review that and take a look at the topics that we have scheduled to talk about. We clearly can migrate from these topics, so there are other things that we haven't included on this agenda that you feel are important for us to discuss. We'll have a period right before the closing where we can talk about what in addition you might want to add to this meeting. And there's actually a little time on day Thursday where we could add a topic. So feel free to let us know if there are other things that you would like to cover. I want to begin the meeting real quickly with some rules of engagement. And to do that, I'm going to turn the time over to Tim just to share those rules.
Okay, thanks, Clay. Let me get those up. All right, so let's start with a couple of basics for rules of engagement for this meeting. Please be clear and concise when you're talking. Feel free to ask for clarification if anything is unclear. We want this to be a safe space for everyone to communicate freely, so please be respectful. And with that, you also should feel free to express any concerns or opinions that you have. Also, please keep yourself muted unless you're talking or asking a question. And then, of course, have fun. We want this to be a good time for all of you. Just a couple other items. With the group as big as it is, we want to make use of the raise hand feature to allow everyone a chance to talk who wants to talk. So before you speak, please raise your hand and someone on the NEMSIS team will call on you to speak. To raise your hand, if you click on the participants and then click on raise hand, you'll see in our picture, Monet has her hand raised. So that will let us know that someone has raised their hand, and then we will let you know when it is your turn to speak. You can also place your questions in the chat or your comments as well if you feel more comfortable communicating with us that way. And then, as Julianne mentioned earlier, we will be making use of the Zoom breakout rooms for some small discussion. So with the Zoom breakout rooms, you will automatically be added to a group. And when the time expires for the breakout session, all of the groups will return to the main meeting. So during the small discussion, if you feel comfortable, if you please turn on your camera for those discussions, as well as decide how you want to participate, if you want to talk or if you want to make use of the chat. And then if each time you're in a group, if you would please appoint a speaker who will report back what your group has discussed to the larger group, that will help us ensure that we hear from most of the groups or all of the groups during the larger discussion. And then finally, allow each member a chance to speak. So are there any questions about our rules of engagement or any other ones that anyone would like to add? All right, well, I will turn it back over to you, Clay. Thank you.
All right, fantastic. I'll mention just briefly in regards to the breakout rooms, there will not be a NEMSIS representative in each of the rooms, simply because we have so many folks that will be joining the call. It would be difficult for us to be there and facilitate those groups and to take notes. The way that we hope to run the small groups, will be lots of opportunities for small groups. We'd like you to self-organize. So during the first group, if you could choose perhaps a facilitator, or if you're all very extroverted, feel free to go ahead and just share your comments. We will ask that you identify a person who can report out. And when we come back together, we will go through 16 groups. So there's a number of groups. So I'll try to facilitate a round robin by going through each of the rooms 1 through 16 and asking for your comments regarding what you talked about in the room. For those who will be reporting out for your room, if the comments that you wanted to share have already been laid out in the discussion, then please just indicate that you are willing to pass as a group and as a room, and we'll move on to the next room or group. That will allow us, hopefully in a fairly short period of time, to get all of the comments out on the table. If there is a need for us to come to some consensus about a topic that would help the NEMSIS TAC or the Office of EMS move forward with some task or deliverable, then we'll develop a poll, and Julianne will be keeping notes. You'll be able to see that on your screen. We'll take the poll. Again, all of this is directed towards us getting ideas out on the table, us discussing their value, and determining what we'd like to move forward with in regards to those ideas. All right. Well, let's dig into our agenda if we could. We are honored today to begin this 3-day Zoom meeting with an opportunity to hear from those who are leading the NEMSIS TAC and leading a lot of efforts on the federal level in regards to the EMS industry. Dr. John Cromer and Mr. Eric Cheney, both from the Office of EMS. For this group, they need no introduction. We appreciate their leadership and are grateful for the opportunity for them to talk with us, particularly during this very unique year where I know they have been incredibly busy on many fronts. So John, I'll turn it over to you.
Thank you, Clay. And we'll just bring up a set of slides here.
We see them, John. Perfect.
Perfect. Thank you so much. Good morning, everyone, and thank you for joining us. We are, as Clay mentioned, doing this as an alternative format from what we typically have done. When the event started this spring, we figured we'd move the meeting back a couple weeks and still be good to be able to get in a face-to-face meeting, and obviously that hasn't been possible. So we appreciate all of you joining us virtually for this meeting. Really look forward to the discussions that we'll be having both with the formal presentations and particularly with the breakout groups. The breakout groups are really when we have an opportunity to share information with each other and then bring it back to the overall group. As Clay mentioned, we have the ability to be a little bit flexible, and we're starting that flexibility out with the initial presentation here. If you looked at the agenda, the presentation for the first hour or so was going to be some comments and discussion led by me. To be very, very candid, as we were putting this together, it became apparent to me, and I made an executive decision, that Eric needed to be involved in this presentation as well. Many of you have been able to engage with Eric for the last year and a half. He has just immersed himself in the NEMSIS activities, and with his past experience in EMS at the local and state level, and now at the federal level, he's been involved in the civilian aspects of it as well as the military aspects of it. Involved with the Department of Homeland Security as they were working on their electronic patient care record, and now with the Office of VMS and focusing on the NEMSIS activity. Clay, I'm sorry, whoops. Let me go back here. Eric just gets it. He understands it. He, by his own admission, is not as tech savvy as many of you are. I'll tell you, he's much more tech savvy than I am. But he gets it, he understands it, and he has a vision for where we need to go and where we want to go. So I think it's important that he be involved in this discussion as well. Before going on, I really want to thank the TAC for all the work that the staff has done, not only in putting this meeting together under these, in this situation, but also in the day-to-day stuff that you all do to support EMS at the local level and at the state level and at the federal level. The TAC has stepped up significantly to a lot of things that we have been faced with this coronavirus activity. And I really want to thank you all and compliment you all on the great work that you are doing. By way of quick overview, as Clay mentioned, I'm John Kramer. I'm the director of the Office of EMS. Eric is the EMS specialist, focusing as the program manager for the NEMSIS activity. For folks that may not understand, the Office of EMS is the office that has responsibility for managing the NEMSIS program and providing oversight for the activities of the Technical Assessment Center. No real conflicts of interest. I'm, by way of fun activities, am the EMS medical director for the Caroline County Department of Emergency Services on the eastern shore of Maryland, but have no other potential conflicts. It's really important as part of our disclosures, however, that we emphasize to you all the importance for both EMS and our Office of EMS for the NEMSIS program for EMS data collection and information handling. This really is one of the most important programs that we work on, and are committed to supporting the program with whatever you all need. It probably seems fairly self-evident, but we can't do what we need to do for EMS, for the activities of our office, for EMS throughout the nation or at the state and local levels, without a solid EMS data infrastructure to depend on. And NEMSIS is a critical component of that. It ties in directly to our mission. Without quality and uniform data at any of these levels, we can't assess our systems. We can't plan for the future of our systems. We can't build on the evidence base that we need to continue to evolve appropriate patient-centered EMS care. I want to do just a very quick historical component here for a second, and it'll be a little bit difficult to do it with the virtual platform. I can't ask a question and have folks immediately shout out their answers, but for you to think about for just a second, when was the first call for a national EMS information system? We typically think that it came about, it was discussed in the 80s, was discussed very seriously in the mid to late 90s, and then we developed NEMSIS. It really goes back much farther than that. Folks remember the white paper that was produced by the National Academies of Science in 1966, Accidental Death and Disability, the Neglected Disease of Modern Society. Well, not too long after that, in May of 1969, the American College of Surgeons Committee on Trauma and the American Academy of Orthopedic Surgeons met in Chicago and developed a white paper that they called Emergency Medical Services Recommendations for an Approach to an Urgent National Problem. As we'll talk about in just a second, that was the first time that we really talked about national EMS consistent data collection and use. There was a chapter in that report entitled Ambulance and Emergency Department Records, and it was written by Peter Safar, who many of us know as one of the founding fathers of EMS. I want to read for you, and it's always boring when somebody reads, but this is a couple of brief comments from that report. And I want you to pay attention to what Dr. Safar reported here. The forms used by police ambulance attendants in Pittsburgh, so that's a reflection of their system, were found to be inadequate for providing retrospective information about the patient's condition and treatment. Ambulance report forms should become uniform on a nationwide basis to permit evaluation of the public health aspects of emergency transportation. Unfortunately, national forms aren't available. The Pittsburgh system used this form as their general patient care reporting form. If the patient had life-threatening injuries, then they had to complete the supplemental table 2 of the patient care report. And if the patient was experiencing a cardiac arrest, they completed table 3 as part of the supplemental form. After completing the form, the attendant is debriefed by the supervising physician, in most cases in that system, an ICU fellow, and the case is discussed at a weekly seminar for all attendants. After debriefing the attendant, the physician adds a short narrative report. The ambulance form becomes part of the emergency room record and the patient's chart. The forms should be changed as necessary for computerized bookkeeping and for prospective studies, such as the evaluation of the quality of patient care. 1969. So fast forward a few years. This goes to the EMS Agenda for the Future, the original Agenda for the Future in 1969, and describes graphically our vision of the EMS system and all of the components that come into play with the EMS system. Remember at this time that this system that was described in the Agenda for the Future was a patient-centric or an EMS-centric way of looking at the system. Now jumping forward to a couple of years ago, the EMS Agenda 2050 project, and the transition that we have made from a patient-centric EMS system to a people-centered EMS system. And the fact that we not only want to pay attention and very close attention to the patient as the center of what we're doing, but we also need to pay attention to the patient's family and the patient's community and the caregivers, including those of us in the EMS community that are providing care. These 6 principles that are outlined here are the guiding principles for the people-centered EMS system. And when we think about the data component of that, it very easily ties in with the principle of inherently safe and effective, and very closely with integrated and seamless, such that we need to tie in our data systems with the rest of the patient's healthcare data. But if you look at the other principles, reliable and prepared, socially equitable, sustainable and efficient, and adaptable and innovative, we can't address any of those guiding principles without focusing very, very closely on data collection, consistent data collection, using that to develop information that then needs to be shared throughout the entire system. So data is a critical component of all 6 of these guiding principles. A couple of years ago, we released a product as a result of work done by a special task force beyond EMS data collection, envisioning an information-driven emergency medical services system. And we talk about a number of components there that were evident in the original EMS Agenda for the Future and are reinforced with the new EMS Agenda for the Future, but continue to point out how we need to approach our data issues throughout. We need to create a system designed for patients, clinicians, and local EMS organizations. You know, historically, data has focused at the state and administrative level on doing audits, providing information, letting us look at the system. That certainly is important. The contribution of data to our research activities is certainly important. But we've got to design it to work most efficiently and effectively for our patients and the clinicians that are doing it. Focus on data, on information that the data provides, not just on the compliance activities that I alluded to just a minute ago. We need to create this information culture. We're a whole lot better at it now than we were even several years ago, but we still have work to do in solidifying that information culture, explaining why the data collection is important and useful, educating the workforce on the importance of data, not just from a documentation of patient care activities, albeit very important, but the other areas where data is important to us, and create a cadre of EMS data experts, both from a day-to-day operational perspective and from a research perspective. And we're getting much better at that. Our data activities have to be intuitive and user-friendly. That's something where we on the federal level and with the TAC need to work very closely with the vendor community in making sure that they are user-friendly and include appropriate language processes. We talk here about the report talked about voice recognition at that time. We need to also now start thinking about video components and how that can fit in more to the patient data collection system and the patient information sharing system. A lot to do. We're making progress. I'm going to turn it now over to Eric to start talking about some of the specific issues that we can talk about today, talk about in the breakout sessions, and focus on during the rest of the meeting. Eric, thank you so much for everything you're doing here. And Derek, you may be on mute. I'll just double check here.
Good. Off mute?
Off mute.
Perfect. Thank you. And you can see my screen?
Yes.
Perfect. I'm just having trouble advancing slides. There we go. Where do we go?
Go back the other way. There you go.
Thank you. So, apologize. As Dr. Kramer pointed out in the very beginning, I have no claim to being the greatest expert in technology, and spend any time with me and you will learn that. I am humbled every time I have a meeting with a group like this, or the state data managers, or with individual states, as Clay and I have been doing, just to learn all the different things that are going on and the different opportunities that we have moving forward. And that's where I want to focus this morning. So how do we move forward? How do we build off of what we initiated in 1969 and have modified a couple times? And now today, as I look forward, need to modify again to keep up with things like the health information exchanges, data exchange, new data elements, new requests for data activities that we receive on a weekly basis, if not a daily basis. That is the challenge. So I find that the most simplistic of tools needed for this position is also the most difficult to master, and that's the ability to listen. So I try to do that. I have taken a little different approach than some of the people who have been in this position in the past, in that I have tried to put myself and Dr. Mann and members of the TAC out in front of any meeting, any conference, any vendor conference that they're requested to participate in, to hear anything that anyone has to say, good, bad, or ugly, so that we can make the changes necessary to move forward. So what I wanted to highlight today is one of the biggest efforts we've taken to point. Back in January, which seems like forever ago now, on the 29th, we held a meeting in Washington, D.C., and we had 131 people from around the country representing health information exchanges, EMS services from small, rural, urban. We had data managers, we had people from the states, we had organizations represented that deal with health information that, quite frankly, until we invited them, I had never heard of before in 30 years of doing this. So we put a large group of people together in the room, and we started to talk about how we can share data between the pre-hospital and hospital and other environments that may be of interest. So what I want to share with you are some of the key points that we gained from that meeting, and we've categorized these. There's a slide deck that's available. There's a brief meeting summary that's also available, and there's a white paper that should be out of clearance any day right now that provides a very large summary of what was discussed. And we can also make a lot of the slide decks available as well from the presenters. So let's talk briefly about standards, because really this is where early this year, Dr. Mann and the TAC and myself and representatives from outside of here that work on standard setting at the federal level were really struggling. You know, we had this issue of HL7. We've been working with that. That's been our platform. FHIR had been discussed. We were trying to figure out, as we move forward, should we be looking at HL7? Should we be looking at FHIR? What should the standard be? And then the Office of the National Coordinator came out with their standards for FHIR for the federal side of the house, which will dictate how hospitals in the future plan if they're going to bill Medicare and Medicaid. So it became sort of the de facto standard. But that still creates a little bit of a problem for us, in that these hospitals and ambulance services, and certainly NEMSIS, We can't change standards on a dime. And a lot of people have invested tens, in some cases, hundreds of millions of dollars on their infrastructure, and they're not just going to go from fire to HL7 overnight. So anything that we do, at least in the short term, and this should be no stranger to those of you that have the discussion on versioning within your state, we're going to have to work on multiple platforms and with multiple versions, at least for the short term. But at least now we know how to plan ahead and what we should be targeting. So we also talked a little bit about the fact that we don't exchange data with the hospitals routinely. We certainly have some places in the country that do, and we're going to talk about them in just a second. But we also need to exchange moving forward with clinics, with primary care physicians' offices, and others. So we can't just target the hospitals per se and accept that as the way ahead. In terms of understanding the requirements that are involved, I hear from the pre-hospital side of the house a lot of times that the hospitals just don't understand our environment. They need to have this data, or this data should be a part of their record. And while I completely agree and fully support that, I think sometimes and it was evident in this group as one of the points they brought up, sometimes there's a lack of understanding on the pre-hospital side of just how they fit into the overall healthcare system. And therefore the data that they collect, how that would be used throughout the overall healthcare system. And you're going to hear me say numerous times, 911 center data is no longer data that sort of sits on the side of the house and we access it when we want specific information on a call or something. As we move forward, especially with ET3 and that model, 911 will become as much a part of the patient record as their past medical history. The healthcare system, how do we interact with the clinicians, and how would that data be, how would the EMS clinicians' data be used by the healthcare system? That was one of the big questions posed by representatives from the hospital side of the house that was participating in this meeting. What should they do with it? What would our recommendations be to them? So there's I'll say, lack of complete understanding of both sides of the house in terms of what each other do. So I'm not naive to the fact that if you're going to make change, there's got to be incentive there. We've already mentioned that hospitals and EMS services have spent millions of dollars on their current systems. We can't ask them to change overnight. And as we do make change, we have to provide some sort of incentive to do that. Along with that incentive is a documented authority, and we've talked about HIPAA in the past at meetings like this. It tends to come up routinely at any national meeting where we're discussing healthcare data. There was a lot of misunderstanding. We worked with the TAC, Dr. Mann and his group contracted with Page, Wolfberg, and Worth as a result of this particular section in this meeting, and asked them to update some existing documents back to 2012. And also to provide sort of a primer for HIPAA on the specific topic of exchanging data with hospitals. And that primer is targeted to the EMS services so that they have the background information that not only says it is perfectly legal and acceptable to exchange data with the hospital, it's actually encouraged by some federal organizations. That document's out there, as well as a brief, about a 2.5-page document that's written for the legalese and for the hospital administrators, so to speak, that says, hey, look, this EMS service is certainly within their rights to ask for this data. It would be great to share this data. It's encouraged. There's no law that prohibits that, and the specific documentation required for that is requested. There's one other document that's also just about complete, and that document is going to target an update from, again, the 2012 HIPAA document that was released that basically provides an overview for just in general EMS services. The fourth one that has not been contracted for yet that we're talking about, and this is something that I hope comes up in one of the discussion rooms today, is for a document that talks about EMS services that specifically enter into health information exchange agreements with hospitals and accept the fact that they're going to have access to that data and are going to use that data. This document is geared towards outlining the responsibilities for that service. Who takes that data on? So what are their responsibilities with that data? How do they have to manage it? And what happens if they have a provider who goes a little bit rogue and goes in and starts to look up their neighbors and other people to find out past medical histories they shouldn't know about? What are the repercussions for them? I think it does two things. One, it's my personal opinion that a lot of the EMS services that want to enter into these agreements haven't thought through some of that. And secondly, I think it would put the hospitals more at ease if you could walk in the door and say, yes, and we are aware of our responsibilities, and here's the training we've put in place to make sure that we keep the data safe. So this creating bridges of islands of success was a topic that just kind of every presentation you could hear there was someone who was successful at doing something, or this was it's almost like if you're buying a new cardiac monitor. Every vendor that walks in the room has the greatest cardiac monitor that ever lived, and their jewel setting is the best because people miraculously live better if you use this monitor versus another one. It was the same way for data. Everybody had a solution. Not everybody. A lot of people had a solution, but it was specific to a smaller area or a small geographical region or to a state or to an urban, but wouldn't fit in rural. And I think we need to build on these islands of success in groups and forums like this so that we can disseminate efforts and not have to pay for the same real estate twice. The value proposition is the perfect example of that. We have to close the loop on these improvements and basically make sure we're not paying 10 different services to develop the same different code, especially since we're all working off of the NEMSIS data standard for the most part. There's some few states that have developed their own state elements, but by and large, I guess my question to them would be, if that's something that state X needs, does state Y need it as well? So should we be sharing those definitions? So the value propositions that we discussed about were providing timely feedback on patient outcomes. And certainly that comes into play on a daily basis with the patients we're taking to hospitals. But it also comes into play on pandemics, where we want to ensure that providers who transport COVID positive patients know that those patients are COVID positive, and it just helps with preventing the disease spread. It's part of their surveillance process, and it's part of the feedback that we should be giving to the individual services. Probably the biggest ticket item out of the whole meeting and discussion, and this is interesting because I highlighted this in red back in early February. Remember, this was January before we really got into the pandemic, and at that time, mental health of EMS personnel, validate their role, help them improve, was one of the big ticket items in that, and I can't think of a more timely, bigger ticket today than that particular topic, and that's why it's highlighted in red. But here's where I think we have to get a little bit smarter at our data usage model. Reporting the fact that 20 providers committed suicide last year is no longer acceptable, at least not to me, and it shouldn't be to you. We have to figure out how we can get out in front of knowing when a person has had enough. And I'm not going to use this as a soapbox to talk about shift length or anything like that, but certainly a provider or a clinician cannot sustain 24 calls in a 24-hour shift 3 days in a row. What is realistic and what are the expectations? How do we measure that? How do we identify what that number is? And when do we say, look, this provider has had enough and they need to come off of an ambulance? Because prevention is the only thing that I can't think of a more important topic in terms of the mental health discussion. So all of these things require real-time communication, and interestingly enough, we had a telephone call this morning where this came up for organizations and states that are allowing 30, 60, 90 days to send in data. That has got to stop. We have got to get to a point where we are working in the last 24 hours across the board, if not real time. But realistically, the way EMS works, and for those of you that are in the field and still very active in the field, you know that you might not be able to complete that patient care report at patient side or at the time you arrive at the hospital. So that's why I say 24 hours and not real time. Real time would be wonderful, but the realistic view of how our system works, 24 hours might be our target. And then the other thing that was a theme in this meeting was we talked about communication back to the service, communication back to the clinician. Dr. Kramer mentioned the goal of 2050 is to become patient-centric. So what about communication back to the patient themselves? Are we following up with them? For some folks, they are. The mobile intensive care, the community paramedicine programs are excellent examples. And are we collecting data on them? Should we? Should it be a standard? Software technology limitations of the ability to segment the electronic health record and share information with EMS. I'm fully convinced that there's nothing that we're doing that's completely impaired by software technology. That everything that we're doing, if we were to look at the barriers, and we're going to touch on those very briefly, the barriers are self-inflicted. They're data use agreements that we need to go back and look at. It's information sharing. In some cases, it's just building our own little empires. We have got to overcome that. So where does this integration start? How does it land? It's coming from NEMSIS, it's coming from the 911 centers. What data does the hospital need? The agreement at the meeting was simply that it can't be a PDF scanned and stuck in the back of the patient's chart. That if the data elements aren't being included and they aren't being searchable, then there was not as much, I won't say there's none, but there's not as much positive use of the data if we can't actually search it. And that goes from pre-hospital environment to the hospital environment and from the hospital environment back. We know that cultural workflows can be barriers. I just mentioned that, it's the way we've done it for 30 years. This is our data. We don't want to let it go. We don't trust this organization, or we like working with this one better. That's difficult to work through, but it's something that we got to do. The sources of truth is the other one. It seems to be that everybody wants to develop a registry, and registries are great and wonderful. Separate data sets are great to work from, but how do we get to the sources of truth? If we're looking at motor vehicle collisions and injury patterns, and we'll just pick the state of Maryland because I happen to grow up there, and we're looking at FARS data from Maryland, NEMSIS data from Maryland, medical examiners data from Maryland, and we have different numbers of crashes and different reports for each for one incident. What is the source of truth? So we need to think a little bit in terms of creating registries versus having one data source as the clearinghouse with access to everyone. And that just takes me through this current state slide. And we'll make these available to anyone who wants them. But the widely disparate capabilities that are out there today, we have great islands of success, and we have people that are really struggling trying to get this done. The EMS records are frequently missing from the electronic healthcare records in the hospital. And then sometimes when they're in there, they're just a scan. I'm not going to go through all of these, just to say our goal is to get to the point where someone is not manually trying to reconcile data, looking at different data sets, trying to piece together one particular incident between the pre-hospital, hospital, and 911, and maybe registry has in the Department of Transportation. So the integration into the hospital role, we heard that loud and clear. We requested funding at the end of this year for monies to support looking at that specifically, and we received that funding. So you're going to hear a lot more about that project starting here in about 3 weeks. So that's an example of, out of some of these meetings, out of these communications and listening sessions that we have, how we can get things like HIPAA documents updated, funding for resources to look at the data exchange between hospital and hospital. And then the big ongoing project that we have, certainly that's going to reshape how we evolve, is ET3. Again, data tracking in ET3 begins with a 911 call. It's an integral part of the model. Whether your success and failure as a part of the ET3 model is whether the patient was actually even transported by the ambulance, whether they were triaged to the right place, based on what could be calls from the 911 center that were triaged out to maybe a home health nurse, home health agency, or to an ambulance service. So what are our challenges? Well, folks, clearly alignment of data. We have to make sure that if we create new data elements or if we create state unique data elements, we can align them to the national standard. For EMS access to the hospital data, to primary care facilities data, what do we want? We've talked about this internally with the TAC and with some large groups. We've had groups say, well, we want the hospital data. And I ask, okay, what data elements do you want? And it usually pause and they look at you and they're like, well, we want it all. So you really want to know that, the patient's supposed to eat these things for the next 2 days and that they're supposed to do seated deep knee bends and, here are the exercises they're supposed to do. Or do you really want to know the outcome and disposition of the patient that you transported in? If you're a primary care, if you're doing community paramedicine, you might want the first part. If you're just doing EMS emergency transport in your area, you might just want the second part. So we have to be careful about what we ask for and be clear about what our expectations are. I said earlier about the next page Wolfberg and Wirth document. What are our responsibilities when we take on that data? Certainly protecting it, keeping it safe, utilizing it in an appropriate manner. And then that goes to the use. What should we do with it? What are we actually planning on doing with this if we got our wishes? The benefits are certainly to the patient. If we can get them more timely, accurate care, to the provider, to the system. The provider piece is the key, again, highlighted in red. We, in the next several years, are going to have huge challenges with provider mental health. And that is absolutely clear. How we're going to manage that, I think, is going to need to be data driven. But again, counting it after the fact is not acceptable. Obstacles, we could probably spend a whole day on that, but we certainly need to identify those. Again, I think a lot of this, and this is my personal opinion, I have yet to be in any of these meetings where someone has pointed out a software or technology problem that could not be overcome. But I've been in a lot of meetings where I've heard people just say, we're not going to do this, or we can't do this, or we don't want to do this. Quality improvement is value focused to me. It's outcomes. We've talked about that for years. There's nothing new there. Treatment validation is evidence-based guidelines are perfect examples of how we're using data for that. The destination validation is the ET3 model. Did we take the right person to the right place? And then time is always important. That's the measure of systems performance. Did the patient do better as a result of our efforts? So we can talk days about mobile integrated healthcare, healthcare plan integration, how that's going to play out, because if the ET3 model is successful in year one, I don't think we're going to see the private payers wait to year 5 at the end of the proposed model pilot program to say, let's integrate this. If they can show they've reduced cost, the private payers are not going to wait till the end of the model to do it. Access to care, always an issue. There's a lot of concern currently in the healthcare environment as to race and ethnicity, social issues in medicine. And I think you're going to see a lot more work on that in the next year to come. Treatment locations, we've talked about already, just to say, look, we've just begun to scratch the surface on what our capabilities are. So my questions for the folks here for today, for now, and for the rest of the 3 days, and for whenever you're up in the middle of the night and you think, hey, I'll just email Eric and we'll see if he's still awake and ask him this question. Where do we go from here? What are the things that you think we should be working on? I've told you and been very forthcoming. I have thoughts in my head for what I think we should do based on efforts that I've heard and meetings that I've participated in. But I truly want to know what you think what we should focus on. Once I have a very definitive plan, Dr. Kramer and Clay will tell you, I am very aggressive about looking for resources. I think those resources are not just NEMSIS TAC resources. I think those resources need to go to state data managers who are struggling in some areas just to keep up with their current crisis. And that was before COVID. Um, and our success is going to be based on collecting that data at that state level. But we have to look beyond the current limitations of those data use agreements, because to do surveillance properly, and we have a great example now, we have to work outside of the current national data set. So where should NHTSA off CMS focus those resources? Are there timelines? Are there certain projects that are more important than others? I'm interested in your perspective. And then finally, and always, if there's anything we can do better, please let me know. And with that, I'll wrap it up and be happy to entertain any questions.
Thanks, Eric. Yeah, take your slides down. I appreciate that. Clay or Julianne, we'll turn it back over to you to pose questions or moderate questions.
Yeah, thank you, John. Appreciate the presentation. That was incredibly helpful. Do folks have questions, either Dr. Kramer or Eric? I'll offer a question. I think that that would be helpful to maybe have a little bit of discussion about. And perhaps others have similar stories on local or state levels. I clearly recognized a new interest in EMS data associated with COVID-19 and trying to wrap our heads around what was happening early on in the fall. And there was an immediate jump, just like almost a knee-jerk reaction to collect hospital data and collect ED data and even nursing home data, which was maybe a little bit out of the ordinary. And I also, as I worked with you two gentlemen, there clearly was a new novel interest, I think, in EMS data. And we were in some ways successful, and in some ways we were not successful, I think, at being able to provide that data. I think we could provide the data, but folks just kind of didn't know what to do with it. I may be speaking a little out of turn, but Dr. Kramer, I know you led the pre-hospital team associated with the HHS healthcare resiliency work groups. I'd like to get your opinion, if you would share it, just on where were we successful there, and some of the states kind of broke rank with some of the contracts that they have in place. For example, the data use agreement with NEMSIS to share data kind of above and beyond. And I'd just like your opinion on how that worked and what's your overall gestalt about what we could have done better.
Clay, interesting question. And there are several components to it. Eric, feel free to chime in at any time. One of there were several things that became apparent early on in this event. EMS as a community has done a really good job of focusing on clinical care issues and having data and information available on clinical care activities. We've not spent a lot of time focusing on the operational side of it. And I'll give you a very concrete example that some of you are aware of because of the PPE reporting tool that was developed. Early on in this event, we were hearing from communities across the nation that PPE, access to it, being able to have appropriate levels, being able to appropriately protect our practitioners was a real issue. The CDC had a reporting process already in place for nursing homes and hospitals that allowed them to report on their levels of PPE. We didn't have that for EMS, which is why we sort of significantly twisted the arm of folks at the TAC and got the PPE reporting tool up and running. When we first looked at some of these operational issues on the EMS side, there just was not information available. Candidly, when EMS agencies were reporting up through their public health or emergency management structures, that also was not getting to, in some cases, wasn't getting consistently to the state levels, and in almost all cases was not getting consistently to the national level. So we need, and we have started a number of those discussions with the TAC, and we'll continue those discussions and expand them out into the community to figure out ways that we can gather more information on operational aspects of what we're doing. Eric alluded to some of the mental health components that we have concern about. We need to, and I know that there are folks that are working on this issue already, but we need to be able to look at the types and volumes of calls that our practitioners respond to. So I'll give you a classic example from my particular system. This was before the COVID event, but we had the same crew over a 3-week period respond to 3 pediatric cardiac arrests. And we can identify that through our routine review process, but we need to have flags built into the system that tells me as the medical director and Mark as our operational director that if you haven't picked up on this, Jim and Sally have done 3 pediatric cardiac arrests in the last 2.5 weeks. So those are some of the kind of operational things that we need to be able to look at. The other thing that we noticed from a national level, and this is, it reinforces what we'll be working on with states and regional and local agencies, is that a lot of the other healthcare information that we have available at the national level, nursing homes, hospitals, ambulatory care clinics, and the like, is much more granular than we have available at the national level. So we're going to have to look at, as Eric mentioned, reevaluating the data use agreements and working very aggressively with the community out there to have access to lower level than just state and regional information that we have access to right now. Folks were very responsive early on in the event when we started to look at ILI illnesses and were able to create initially the ILI dashboard. We then looked at cardiac arrests and overall responses and things like that. These are the types of information that are now available to you all through the weekly, and I just drew a blank on what we're calling the report, the weekly snapshot.
EMS by the numbers.
EMS by the numbers, thank you, Eric. We need to continue to work on improving and expanding those capabilities. So those are, the other thing at the national level, and this will be no surprise to anybody, but there really is, among the non-EMS federal stakeholders, a gross lack of understanding of the capabilities and the activities of EMS agencies around the country. You know, when we first started to talk about treatment in place, there were folks that had no clue that one, that was an option, two, it was being conducted, and three, the EMS resources are very appropriate for being able to do those types of activities. So we do need to work on better understanding all over the place of EMS resources and capabilities. Those are probably the three things that stick out in my mind.
Good morning. We have a question from Doug Bullard from Image Trend.
Good morning. Dr. Kramer or Eric, I'm just wondering if you guys have ever thought about forming a advisory committee using from medical directors, maybe from someone from NAMSP, as we are looking more into the data quality and data usage, like the defined list. It'd be nice to have industry experts that is advising NEMSIS and can help steer maybe these lists and ensure that we have some data quality and real life kind of medical director kind of perspective. I don't know if you guys have ever thought about that.
Actually, we have. Thank you. We have actually put together, we had planned on doing this back in January, right after the data summit, another lesson learned out of that. But we identified two specific groups. One is we called the internal group, and the other was the external group. The internal group is a data group specifically to look at things like you're saying. How do we get that data clarity? How do we get the most out of our data with the least amount of effort on the part of the clinician? This is, it's like a small working group, people like you described, and then an external group that looks at sort of the big picture, the macro picture for technology. So a project that's ongoing right now is the move of NEMSIS data, and it is very early in its stages from its current Utah environment into the Department of Transportation as the hosting center, with Clay and the TAC basically managing the project and doing all of the work that they currently do. But the hosting has to meet federal guidelines now because it's a federal project, and that could be another discussion. But essentially, once it's in the cloud environment, can we capitalize on that to do things that we're not doing now? What are some of the other big picture things that we should be looking at, 3 to 5 years down the line? Realizing, for those of you who don't work in budgets and federal government, we are looking at 2022 right now. So things that we're going to do in 2022 is what we're planning budgetary wise for our office. So thank you for the question. We certainly are. The makeup of the committee is pretty diverse, but I was adamant about one thing. The dominant group in that committee are field level providers for the internal side, because the one piece that keeps coming up again in all the meetings is we can't keep adding data elements to the providers. We can't just keep adding things. We have to be smart about what we're putting in there, and make it very clear. That goes back to the clarity part of the report that Dr. Kramer mentioned. So I think we've started to tie it together. I just real quickly, because I know we're close to time. One of the things that we also learned out of this recent events, we developed this resource reporting tool, and then we found out that there were, with the exception of one state, Amber, who from Colorado, was very vocal about it early on, that they had developed a product similar to this, but we didn't know that there were other states that have done that. I bring that up only to say this. One, thanks, Amber. Second, we have got to get better, we being myself and Clay and others at our level, to start to understand what's already been done, to make sure we're not duplicating work with the states. So our communication with the data managers and state directors have to be better. We started a monthly report now that I give to the NEMSIS board of directors that talks about what projects we're doing, what presentations we're doing, data requests that have made to us for research, and a whole host of other topics that Chris at the TAC is working on a routine basis. So the communication piece from us to the participants on the line and others is huge for us. Over.
Doug, thanks for your question and comment, and focus on medical directors. I appreciate that. As Eric alluded to, the group does include medical directors, but the entire spectrum of other folks that need to be in this process. I'll also just share with folks, and I'm very pleased with this, there are a lot of medical directors out there that are not hesitant to contact me when they have questions or comments or observations and suggestions. The other thing I want to comment on, I'm getting some comments that you all are getting background noise with my audio, and I apologize for that. I thought we had fixed it. That's a computer issue because it doesn't make any difference whether I use a headset or what headset I use, so I'll try and be quiet.
Do we have time for one more question from Kelly Clark at Image Trend?
Go for it.
Hi, Eric. You mentioned that you have a monthly report of projects that you're working on. I would really love to learn more about those projects and if ImageTrend can contribute or help with some of the state information that you're wanting to collect or expand on. I would love to hear about that and help you in any way if we can provide additional information to help with those projects. Is that something you would be able to share more information about?
Absolutely, Kelly. Let me talk to Clay and him. We haven't really set up a distribution for that yet. We originally just developed it for a request, but I don't see why it can't go out to anybody who wants to see it. Let me talk with him. We are in this will be our 3rd edition. So it is still very new in development. In fact, we keep asking the small groups that we've sent it to if there's other topics that they want put in there. So again, in terms of improving communication, if that's what it takes, it's just a matter of sending it to a different group. So the answer to your question is I would love to make sure you have all the information you need.
Thank you. I really appreciate it. I'm excited to hear that and see if we can help in any way possible.
Thank you, Kelly. This is Clay again. We do have time. We have until 10:15 Mountain Time. So I want to make use of every single minute we have with these gentlemen. I think it's incredibly valuable. I'm gonna ask one more question for a brief answer, and if there's others who have questions, let's make full use of the time. Eric, I wanted to just ask you a question about related to what John was talking about, the reevaluation of the data use agreements among the states, and what can and can't be shared at a public level associated with the national NEMSIS data. I wonder if you have perspective on this a little bit. I know that there were vendors, and of course, the NEMSIS TAC made data available to CDC, to HHS, and to others very early on. The public data set, right, that didn't really allow for geographic identifiers, for example, to be released. And I don't know whether that data was used to its full potential. I just wonder from a national level, if you could speak to really how much our value of our data was curtailed by the fact that geographic identifiers weren't available at the federal level.
Yeah, Clay, that's a good question. The answer is it's pretty substantial in terms of the hit we took by not being able to present at that level, the data at that level. Palantir was the company that was hired by HHS early on to pull together literally hundreds of data sources, and the TAC and myself and a few others had the opportunity to get sort of a virtual tour of how this thing comes together. And it is, to me, completely mind-boggling the number of data sets they were trying to pull together. But the real value, and where they sort of backed off a little bit, was they didn't have the ability to tie that down to a specific area of the country because they didn't have, and I'm probably butchering what codes they were, but they didn't have that data that they needed to get that specific for location. It also came up again with hospitals and offloading times. Uh, it's interesting how certain things become a big topic at the federal level. One of the things that really hit and I guess it hit the press and made such a big splash, was that ambulances were sitting outside the hospitals for hours and hours at a time. So we got a question about offload times, which we could give them some aggregate data on, but they were specifically wanting to know, at a county level or at a specific hospital or a specific region, what were the offload times and how were they impacted by the increase in COVID and the hotspots, so to speak. And especially when they were sending teams out to those hotspots, we were pulling general data for them, as much as we could and as much as we had available, but they certainly wanted more specificity and more detail. I will tell you that we have, um, some of you have heard this, some of you may not. We have data use agreements with the CDC. The CDC gets the public use data set and is using it on a routine basis. We had a request the other day from the FDA, to look at very specific data. We are getting a lot more federal interest, and their interests are far more detailed than we currently have the capability to provide. I mentioned that to say that if we want to grow, and I'm always looking at the resource side of things. If we want organizations like this to resource our state level data managers and our programs, we have to be able to meet those needs. We can't say, we can't give you that data, but we'll take your money. That's just the way it works. So this whole thing is really it's kind of like a patchwork quilt. There's all these different really intricate, neat pieces, and some of them by themselves are really good, and some of them sewn together and make a really nice pattern. But it can be absolutely gorgeous and a beautiful product if it's all put together right. And I think that's what we're trying to figure out. Kelly, I really appreciate your comments, because early on I reached out to quite a few vendors, and said, hey, look, how can you help out with this effort? I mean, it's all fair to say everything's online. ESO had one of the great burn rate calculators early on. ImageTrend was able to provide very similar data in a very timely manner, so that made it very interesting. Different other organizations that we worked with, like FirstNet, we talked to them. It's trying to pull all these groups together and learning how to communicate with them is quite challenging. And that's along the lines of my questions. What can I do better? I mean, I'm open to any ways to do that. I mean, the best example I can give you in that process is when I was talking to the state data managers early on, I made the assumption that that information was also getting to the state directors, the state EMS directors. And in a conversation with Dia, she was like, hey, look, you can't make that assumption. And until she, kind of called me on the carpet about it, I didn't realize that was the case. So now I do. So now I have a better understanding of, and that's part of the reason why we created this monthly report. So any little things like that we can do to make this more clear, to be completely transparent, I'm more than willing to do those things, but I'm always looking for help, and I'm certainly always looking for your expertise.
Yeah, Clay, I'll just add a quick postscript to that. Eric was spot on with his comments. The short answer to your question is the current structure that we have for data collection at the national level and information sharing is inadequate, and we have to work on improving that.
Yeah, thank you, John. I appreciate that very much. We've gone right to the hour with John and Eric. Thank you very, very much. If folks have other questions they'd like to chat with these folks about, feel free to do that on the private chat. All right, folks, let's get moving. It was really great to have folks from the Office of EMS at NHTSA to talk to us about what's happening with the NEMSIS data, particularly at the national and federal level in response to COVID-19. What we'd hoped to do with this first hour that we have, where we'll be breaking into subgroups, is to maybe talk a little bit about our response to COVID-19. So Eric and John gave us great information about how NEMSIS data was utilized at the national level, some of the things that were successful, some of the things that were not so successful at the national level. What I'd like to cover and have you discuss in your small groups is whether or not we were successful at the state and the agency level, and what in addition we could have done or should consider doing as we're moving forward. We're clearly not done with the pandemic yet. What should we be thinking about in regards to further work? Keep in mind the NEMSIS TAC, and particularly the Office of EMS, remains very cognizant that changes to the NEMSIS standard are costly in a number of different ways. And so there's clearly a return on investment that needs to be evaluated if any formal permanent changes made to the standard. But here I highlight just the things that we did do early on in the pandemic that hopefully helped states and agencies be able to respond more appropriately with data that could be helpful at the local and state levels. I'm just showing here a quick snapshot of the brochure that we made available. And Julianne, if you'd be so kind as to post the link to this, and so folks can download it if they want to. We developed 6 custom elements. You can see those listed here, mostly related to either recent travel or recent exposures. This was early on when community spread was just beginning, and so hopefully those were of value. We also added 7 custom values to existing elements, and those are available here on the bottom of your screen under additional values. And you can see we added PPE, an alternate care site, a number of different things that dealt with either the new technology or new patterns of transporting patients that were associated with our response to COVID-19. And then finally, Eric mentioned the Red Cap survey that we put together in regards to trying to provide a way at the national level for them to have an understanding of where we have needs for PPE, how much our agencies are under stress due to COVID, and really the man shortages that have resulted due to those infections. Also, I'll just mention, we also had an ICD-10 CM recommendation, and that's because the current pattern associated with NEMSIS and associated with primary and secondary impressions does not include the U codes of ICD-10. And so CDC was suggesting that folks utilize a U code to indicate a COVID exposure. We asked folks to use a B code instead to talk about a potential coronavirus exposure. B codes were open to the NEMSIS standard. Even today, U codes are not present in the current standard, so maybe that is a recommendation that we need to make. We didn't include U codes because they are, U codes are left for experimental or temporary codes. I imagine that the COVID-19 code will move into the B section soon, but maybe we need to open up that section and include it in the standard. That would be a great recommendation that could be made by this group. So we're going to go ahead and break out, just with that background as to what we have accomplished in regards to our response to the COVID pandemic. I'd love to ask these questions in the breakout sessions. These breakout sessions will last for 10 minutes and they'll be timed. You'll see when you're getting close to your 10 minutes, and so try to wrap up your conversations at that time. As I mentioned, we'd ask that you self-organize and that you be prepared to report out in 2-minute reports for each of our 16 groups at most. If you come up with recommendations that have already been stated by a prior group, if you just indicate that your group can pass, that would be great. But these are the questions that we'd like you to consider and come back to us with recommendations for us to consider as we're moving forward with the pandemic and just in this next funding year. So what attributes of the EMS response to COVID-19 were not adequately addressed by the custom elements or values that I described just a couple moments ago? What did we not consider that could have been helpful at a local agency or a state level? And so what do we need to consider in the future as we're moving forward? Some of those things may still be pertinent. Some of those things may not be. We'd still like to know what you think did not work well historically. And then also moving forward, right, we're still in the midst of this. We have new threats coming online. We have kids back at school now. We have influenza season coming up. And if we develop community vaccination programs and trying to provide a vaccine for the entire nation, we may be called upon as pre-hospital providers to help with those programs. And are there other things that we should be considering and making sure that we can track through our EMS systems? So those are the two questions. They're related. What historically could we have done better in regards to data collection that would have been helpful at the state and the local level? And moving forward with the things we know are in front of us, or the things that are in front of us right now, are there other things that we should consider in regards to the NEMSIS standard that would be helpful? So I'm going to have Chris go ahead and break you into your groups. You have 10 minutes to discuss these two topics and come back to us with recommendations, and we'll go through each of the groups, each of the rooms one by one. Okay, great. I'm gonna suppose that people are back. We may have some additional stragglers come back from the groups. Thank you very much for taking the time. I know it was short, only 10 minutes, but hopefully as we move forward with the groups through the next couple of days, and today actually we'll do another group, hoping that you had time to organize a little bit and things will be a little bit more efficient next time. So here are the two questions that we asked you to respond to. What attributes of our response to COVID-19 were not adequately addressed by the work that we did, either custom elements, values, or the ICD-10 codes? Were there things that we could have done better? And then preemptively moving forward into the fall here with the pandemic, what additional things should we be looking at in regards to custom elements or values or other data that we probably should be considering to collect? Julianne, I'm going to ask if you might be willing to take notes, and I'll let you share your screen if you would. And I'm just going to walk down through each of the groups. We had 16 groups. Hopefully folks had a chance to assign someone who might be willing to just share a couple of comments with us. We'd ask that you keep it to 2 minutes at maximum. If the things you were going to report out are already covered by a previous group, if you would just pass, that would be great. Really what we're hoping to do here is to basically collect information that we as a group can come back during our bi-monthly calls and dig into deeper and determine the best approach to take. But really what's valuable about this meeting is having all these experiences that occurred during this spring, everyone in a different area of EMS industry. We can collect your thoughts and consensus about what we could do better, what we could do in the future. We'll take those things and then we'll refine them over our bi-monthly calls. So I'm going to go ahead and begin by calling on breakout room number 1. Could you report out for us? You may have to remove yourself from mute.
Which one was breakout room number 1?
I think that was our room. Yeah, we got a little bit of a slow start, not knowing if we were a full room or not. We talked about the ICD-10 codes, having those be maybe extending to accommodate the U codes, where future codes might be in there. We didn't have too many other comments on the ones that were added, but trying to have some way of we talked about, it didn't have like a general consensus, but it came up as well of having some choice for a general option of surveillance data points, similar to an impression code, but just say this person might have whatever's going around the current pandemic. Just to bring that up if other people want to tack onto that. That sounds good, Samantha, Josh?
Yeah, I think so.
Yep, that sounds good.
Yeah, thank you, David. Appreciate that. All right, breakout room number 2.
Yes, we had two big thoughts. First one, overall, we like to see it baked in future releases, so that's not custom elements. Some of the states were averse to using non-custom elements in general, and others prefer to keep the custom elements specifically for state use only, because there's like a loss of fidelity and some confusion about how to not get it implemented, or it was implemented incorrectly. And so if it was already in there in the go and was standardized, that we felt that might be better moving forward.
Oh, great, Matthew. So, so overall, was kind of the idea that maybe some of these codes could become part of the standard. Is that kind of what you're saying?
Yeah.
Okay. All right. Thank you, Matthew. Breakout room number 3. All right, we'll come back to 3. Breakout room number 4.
I think I was number 4. We had I posed the question, since I'm representing a vendor here, I posed a question to the states, were there elements that weren't already being tracked, or was there something that you saw a deficiency in? And I heard from Orange County, California, that said, they were already utilizing data collection elements, so it really wasn't necessary to add additional elements for them. They were already tracking ILI, and being out of flu season, they sort of started to see a spike when COVID-19 arrived. The only thing that they implemented was the adding some of the impressions as a secondary impression, but for the most part, they really didn't utilize a lot of what was added as custom elements. So we didn't get to the second question, but that's sort of the gist of the conversation we had.
Thank you, Andrew. Appreciate that. Breakout room number 5.
Clay, this is Sue with room number 3. I'm unmuted now.
Hey, Sue. Great. Yeah, can you report out for us for breakout room number 3?
Yes, please. The reuse of PPE was something that was a needed custom element. It was created by some softwares for the use of the states that requested it. The international questions didn't seem to be as relevant once it spread to being to the United States. And there was a lack of the definition of the word community. What did one mean by that? They also said there was a need for tracking of contact, but this would be more of a public health question. And then that brought us into a whole discussion of the use of an ePCR, being that it's a documentation of patient care. Where would it work to have an administrative addendum to have that question answered later, not while actively providing patient care?
Okay, great, Sue. Yeah, great points. Yeah, thank you. We discussed a number of those with the development of those elements, but those are very helpful. Yeah, thank you. Anyway, breakout group number 5.
Hey, this is Nate Crabb with breakout room number 5. We'll be sure to establish a leader next time. I think that's why we had the pause. So we talked about a couple things that were already mentioned, so I won't go over those. We did talk about the speed of establishing what the custom elements were going to be to track the COVID stuff. It did take a couple months, so having those ready earlier would have helped to make sure that we could start collecting that data. And we did talk a little bit about maybe having a series of different kinds of elements for different kinds of breakouts or different situations that we might want to be collecting earlier. And then maybe having some trial runs. So we're coming up on influenza season. So maybe we look into establishing, hey, what are some things we'd track for an influenza type thing, and then enable those for the influenza season and see how that goes. And then a little bit from San Diego to some monitoring of different things, like what supplies are being consumed, what kind of impressions they're getting from the providers, things like that, to try to alert earlier to, hey, is there some kind of breakout that's happening that we should be alerting others to? So it'd be cool if we could have some kind of higher level thing like that happening on the NEMSIS level or the state level to say, we're seeing these kinds of common things popping up everywhere. Is this something we should be concerned about on a bigger level?
Great, Nate. Thank you. Great comments. Appreciate that very much. Breakout group number 6.
Hi, Clay. This is James for breakout number 6. I think really the only thing we needed to add is to Matthew's suggestion up at the top about the states adverse to using the custom elements. It's more in line of a lot of the states chose not to even accept the custom elements. So it took a lot of development time to actually remove those so that we could actually have those states process all of the other data. So, having everybody on kind of the same page, where if it's a national element, they accept it, doesn't mean that they have to use it, but they should at least be able to accept it.
Yeah, thank you, James. Yeah, great comment. That clarifies Matthew's statement. Thank you. Breakout group number 7.
Hey, Clay, this is Eric. I'll just give you a couple notes. Ours were we focused a little bit more on the process piece. One of the questions was, or one of the comments was, reporting the same thing over and over again. How many times are we going to ask the same question? So, repeated questions was an identified topic. The process of implementation, this is a cost thing for vendors, and that led us into, is it better to have, if we have 4 data elements, it's better to release 2 at one time than have 1 each week for 2 weeks. So if we can group them, and then certainly, as someone else said, get out ahead of it instead of being responsive. Over.
Thank you, Eric. Appreciate it. Breakout room number 8.
So we had a resounding ditto for the get out ahead of it, be more agile when it comes to implementing these things. With the bi-weekly calls, it just took a long time to get these things done. One thing that we found as vendors, sort of a common theme, was when we started adding city-state questions, we had to try to make thoughtful designs for our customers and selection list, and that became sort of a road bump in development as far as that goes, as well as the addition to the U codes and the ICD-10 list. Those of us who sort of function and overlap with billing companies, and not having those codes being allowable in XSD still kind of proves to be somewhat of a problem.
Thank you, Keenan. Yeah, appreciate that. Breakout room number 9. Ridgely.
You guys already covered it.
Okay. Okay. Thank you, Ridgely. Appreciate it. Breakout room number 10.
So I was in this one and I took some notes. I didn't have any good ideas though. All credit to the group. The only things that aren't addressed here are second on the prep time, and then a list of states that were implementing the custom elements was something they would have liked to see. And then for preemptive issues, a question came up. Will EMS be involved in any testing processes for COVID or influenza, and how would that be tracked? Sorry, I talked way faster than you could type, Julianne.
Yep, you're gonna have to give me that last one again. Testing?
Yes, COVID and influenza testing. Will EMS be involved in any of those processes, and how would that be tracked?
Right. So vaccination programs, how we could potentially help. Is that correct, Laurel?
Yeah, mostly just curiosity about how that would be implemented, but also I think, when looking at how to collect that information, because of course we would want to collect the information.
Great. Okay, thank you. Breakout room number 11.
A lot of things were already mentioned from our discussion. One of the things that was brought up was ICD-10 codes for telemedicine. Maybe an improvement on finding those specific values. I think that other vendors were not liking the custom elements for the COVID field, so maybe standardizing that, like was mentioned above. As far as the vaccine question and how to track that, maybe having a way to track when the vaccine was actually administered and any symptoms that might arise of that, so we can track that internally as well.
All right, thank you, Kelly. Yeah, good comments. Breakout room number 12. Okay, we'll come back to breakout room number 12. Breakout room number 13.
Oh, sorry, this is Peter with 12. I had myself on mute.
Oh, Peter. Yeah.
So a lot of stuff was already covered that we spoke about. One of the things that we had a pretty good discussion around was the fact that we're not the only ones that were interested in capturing this information. Specifically, NFIRS was capturing the data similarly, but not exactly the same. So we were doubling up on our documentation. So maybe possibly working with, we don't live in a silo. We're not the only ones in healthcare. Is anybody else doing the same thing? And how can we kind of all work together on that?
Great comment, Peter. Yeah, thank you for that group. That's a good comment. Breakout group 13.
Hi, this is Ryan. A lot of things that we talked about were already said on this list. I just wanted to mention again the importance of, we really should be putting these custom elements into the standard in either the next version of the standard, or if even maybe a critical patch of 3.5. I know these questions came out pretty much when 3.5 was just finalized, so we kind of missed that. But and kind of in the same vein, but the fact that the geographic questions, they were defined as type other in the definition, and that's not something that anybody can plan programmatically for. That's just a comment on the implementation.
Would you repeat that? Let me catch that.
Yeah, so the definition for e-custom configuration for the 3 geographic related questions, the one that was state, country, and city, they were defined as type other, which is something that a software can't really enumerate for beforehand. So there were a lot of us that were vendors found that it was just very tough to implement. Not only just the fact that, I think somebody mentioned before, making a nice UI for our clients, but also the fact that, we don't want to show them the straight codes. We don't want them to enter the straight codes. It was just a brand new thing that had to be implemented just for those questions.
Yeah, Ryan, good comments. Yep. Yeah, thank you. Breakout room 14.
Hey, Clay, this is Jen.
Hey, Jen.
So the only thing that we really discussed that isn't already on here is the international question with whether or not the region of an international country needs to be captured. The example that was used was if somebody had come from Wuhan, China, as opposed to some other place in China, it might have put a different emphasis on it. But there's also concern with, making drop downs too long with pick from the top or anything like that happening. So we didn't discuss how, different ways we thought it should be implemented. And that was pretty much the only thing. As far as the second one with the influenza and vaccination, we talked about, influenza versus COVID, using the symptoms and as a heavier indication rather than the specific impression codes for COVID. And that the exposure question, along with destination alerts and stuff, is a really good emphasis for those patients. And that was pretty much our whole discussion.
Great, Jan, very helpful. Breakout room 15.
Dr. Mann, thank you for the opportunity. This is Jason Oko from Maine. We did talk about some of the things that each state kind of did in this, and one of the things that we specifically talked about was defining a way to document whether or not your patient is a PUI, person under investigation, because that was the one thing that sort of the AFib of the whole outbreak, the consistently inconsistent symptoms that were there with PUIs. But if you could say, hey, yes, they match the criteria, that would be a great tracking tool. In terms of the vaccine administration, one thing that we've kind of noticed from our state anyway is that a lot number for a vaccine, if we're documenting that, we would need to add a lot number to that field. And then also thoughts on a way, because several of the vaccines that are coming out are talking about this is a 2-cycle vaccine. So you need either one dose and then 21 days later another, or 28 days later another dose. Documenting for how to remind the patient, hey, you got to get another dose in 21 days or 28 days if the system has the capacity to do that. Thank you.
Great, Jason. Great comments. Appreciate that very much. Breakout room 16.
I had to unmute. Yeah, from our side, this is Christian Witt from BLT. One of the things that we were going over as we were kind of looking at the custom elements and stuff like that was whether, and I think we're focusing on the second question, by the way, not this particular one. But the question was what things to add and take into account for this fall. And family members that are exhibiting flu-like symptoms was one of the ones that came up. And also whether they had already had something like the flu vaccine or even the pneumonia vaccine. But there was also a discussion in our group about how charting is already complex, and a lot of people complain about how many elements they have to enter. And so the question of, okay, if there's going to be an PNNV value, most people are just going to go for that, even if it's something that is being required. And so just understanding that we don't necessarily see what is happening until the data is received and we start going over it, and that's quite a lag period to understand how much people are actually using these data elements and entering or ignoring them.
Thank you, Christian. Yeah, appreciate that. Great comments related both to important issues, but also the idea of not overwhelming our providers. Incredibly helpful. Hey, Chris, so I think we only had 16 breakout rooms. Is that correct, Chris?
Yes.
Okay, all right, thank you. Yeah, appreciate everybody responding. So these are great comments. We have this in recording, and we also have the summary here that Julianne has been providing. We will aggregate this information and run it by the Office of EMS, and then also provide this as a discussion point in one of our upcoming bi-monthly calls. Probably our next call, just to ensure that we can cover these issues and try to refine down some of these things. Clearly a lot of great ideas, so thank you very much for doing that. That was incredibly helpful, very helpful. All right, I want to, if it's okay, I'm gonna share my screen back if I could. Yeah, thank you. So I want to have us break out just one more time, if we could, on a related question. And it kind of relates to the topics that we should preemptively consider as we move into the fall. This is the idea that's been mentioned here several times already about the value during the pandemic of being able to somehow evaluate EMS resources. PPE shortages, COVID exposures, manpower shortages, even questions about financial viability, right? There was a call nationally for us to be able to provide information in regards to the health of our pre-hospital environment. One of the ideas, well, so the quick and dirty way to answer those questions was for us to develop just a freestanding red cap survey that's available on the NEMSIS website. I would say on average 200 to 250 agencies across the country put data into that on a weekly basis out of the 10,000 agencies. Several states have decided not to use that because they have other systems in place, and that's completely understandable. We were kind of late at the game coming to that. Other states are mandating its use, finding it incredibly helpful in that they had systems in place that weren't working as well as they'd liked. So the other idea that's come up is to maybe evaluating the idea of being able to utilize the NEMSIS demographic data sets section to answer some of these questions. The theory behind this, of course, is that the DEM section is something that can be updated as currently can be updated and submitted to states and national elements to the national repository as we update vehicles, as we update personnel, as we change addresses for agency locations. Those can be updated and resent, and a process is in place to ensure those are updated. So the idea is, in this next breakout session, should we or could we use the NEMSIS DEM section to address questions like this? Is this a viable idea? And if it's not if your group thinks it's not a viable idea, what is an alternative, right? We have just a freestanding survey now available, and it's only been out for a couple of weeks, really about 3 weeks. And so maybe it'll catch on. It's really built only for agencies that are suffering some type of shortage or stress. And so maybe there's lots of agencies that just aren't using it because everything is going smoothly right now. Maybe that's the option we need to stick with. But in the long run, being able to provide data at a national level that speaks to these ideas for this pandemic and in other things, it may be valuable to have the DEM file include some resource-related items. So the question for your next breakout is this a viable approach? And if yes, if there's something in addition to those 4 topics that might be valuable to capture, then please let us know when you report out if there are other items that might be valuable. If this doesn't seem to be a valuable approach, then yes, let's talk about another long-term solution that may be able to provide this information to FEMA and other national partners that can use this data to help us forward our industry. So Chris, I'm going to ask you to move folks into their breakout rooms again with this question in mind. Should or could the NEMSIS dataset section be used to address resource-related issues? Let's go ahead and do report outs associated with this question of should or could, how we could collect resource-based information regarding our EMS agencies. Can we use the DEM data set? Is that a viable approach? I'm going to go in reverse order if that's okay. I think then we can get a fresh view on this item by reversing the order. And do you want to go ahead and take the screen Julianne?
Sure will.
Report the findings. All right. All right, let's begin with breakout room 17. Oh, excuse me, group 16, Christian, I'm sorry, group 16. We don't have a group 17. Sorry about that, I apologize.
I thought you added a new group. Can you hear me?
Yeah.
Yeah, Christian, can hear you.
All right, this is John. We did talk about it. We didn't come up with a definitive answer, but we said it could make sense. But the agencies aren't really in the demographic data set making changes often, and it would require them to use this section considerably more often. So our concern was stale data. We feel like you'd be left with stale data quite often. So can we do it? Yes. Is it a good idea? Probably not. There was some discussion around, pop-up data in the field to collect it at each login. We could use that then to populate the data set, but asking a field medic this question could get incorrect results for the company as a whole, meaning that they may not have it on the rig with them, but the company may be fully stocked with PPE. We discussed having a report for an agency that could be provided upstream to relay this information. Have to create one of those. That was another option.
Okay, John, thank you. Yeah, appreciate it. Breakout group 15.
All right, I think I was 15, or a bunch of us were 15. We had the same thing. I mean, quick answer is, could the DEM section be used? Yes, if we can't find any better option. But similar, it was difficult to get folks to collect information in that section and update it. It might be better just on the site and we direct people to there. I had the idea of, if we had some type of API, we could push stuff to NEMSIS, but it wouldn't be part of the DEM data set in that idea. Financial emergencies might not be really part of the ePCR application. Let's see, person power staffing, not PCR. Oh yeah, doing a lot of staffing might not be in the PCR unless the platform does both. I'm just reading my notes. So kind of the same thing. We don't really see that being the solution, but couldn't come up with the other answer about what would be the solution.
Okay, Adam, thank you. Appreciate that. Breakout group 17, or excuse me, 14. I apologize, 14.
You really want a 17 today, don't you, Cliff?
No, Jen, I don't.
Okay, so we kind of said the same things that you guys have said. It is possible to use the DEM elements, but should we? Same concerns with how real time would it be? If there's going to be decisions based on that data and the data is a month old, it's not something that should be actively used for decision making. Also, how would the data be used? Is there going to be NEMSIS reports that would be based on it? And again, the age was a concern. Some concern over, is it what we already collect in other places in the event file as well? And that's what the crews should be doing. The demographic files are sent separately, and only states with a mandate for the demographics might be able to keep this more up to date and find it more useful. States without any mandate for the demographics may not be able to find it useful. It was also brought up that it could be kind of a chicken and egg situation where maybe if it's put in the DEM file, more states would start requiring the information. And then another item was brought up about the data integrity for the rest of the DEM file. So if you mandate that it comes in weekly, are you also keeping up everything else that's in the DEM file on that often of a basis?
Thank you, Jen. Breakout group 13.
Hey, so a lot of the points that we talked about were also already mentioned here. The first bullet point I think was the biggest item that kind of led us towards a could we? Yes. Should we? is it worth it? Because again, agencies, they do not update their DEMs as often as they should today. The other thing was some of these questions, we would have to know where the best, I guess, benefit would come from, whether it's funding related, whether it's something needed at the national level, et cetera. It's possible that questions like that might not be needed at the national level, but maybe could be handled by custom elements per state. And I think that's about it.
Yeah, thanks, Ryan. That's a good idea. A breakout group 12.
Unmuted this time. Okay, so one of the big things that came up with us was that the DEM file is already pretty complicated, and like everybody else says, it's not being updated by agencies that frequently. So we didn't think that the DEM file was really the place to put it. We came up with the idea of, again, maybe some API that this data could be pushed to from some tool. Or, you know, maybe this is something that requires its own data set that would have, you know, this kind of information in the same way that the state has its own data set. Let's see, we did have a question about the financial viability. Were we asking about the financial viability of the agency or the financial viability of making this a thing? So we weren't super clear on that.
Yeah,
Okay,
thank
so,
you for the agency. Yeah.
Yeah, and then it comes down to, do they want to be sending that kind of information up the chain?
Okay. Okay, Peter, thank you. Breakout group 11.
Hi, we had a lot of the same concerns. The demographic file is not necessarily being updated constantly by agencies. And with that, the states would have to implement some type of workflow to ensure that they actually are getting the demographics in a timely fashion and making sure that it's up to date. I don't think that that's impossible, but it definitely would take some planning and implementing a workflow to ensure that agencies are getting their demographics to the states and the states to you guys in a timely fashion. One of the biggest concerns would be for states like Pennsylvania, who's a Commonwealth. They can't enforce EPCRs or demographic files within 72 hours. And if they do enforce that, it would actually have to be a state law. So for Pennsylvania and other Commonwealth states, that might be an even bigger issue.
Thank you, Kelly. Good thought.
Thank you.
Breakout group 10.
Yeah, just had some similar concerns about utilizing the DEM for this. Some of those would be in terms of the type of data that's already been collected by the DEM data set, this new set doesn't really fit with that. And, you know, if we allow this kind of data, it would just be a mark to keep growing the DEM data set. Also, there was some concerns about bordering on potentially collecting too much information about the agency, you know, like personal agency information. Let's see. And I think a lot of these other points have been touched on.
Okay, Chris. Yeah, thank you. Appreciate that. Breakout group number 9.
Hi, it's Ridgely. Can you hear me?
Yeah, Ridgely. Hi.
Hi. Yeah. So we kind of had some of the same concerns about using the DEM file. You know, coming from a state that we don't collect the DEM file because the understanding is that you can cause more problems by bringing it in than just not using it at all. We thought of collecting it at the incident level, so that would be more of a, you know, per call where the EMT's missing things that they needed. And as somebody said earlier, you know, that can be skewed, and maybe there's something more going on at the service level that they actually have it. But I guess it depends on what your goal is with it. So if it's to, you know, make the case that they're not getting what they need, that would work. But if it's trying to get something at a higher level that's more accurate. And then I guess my question on this was, where does the new, you know, independent PPE survey system fall into this whole equation?
Right. Yeah, thank you. Yeah, the independent survey that's out there now, the Red Cap survey, was just kind of a quick stopgap to make the make approach available quickly. So something like this would replace it, right? I mean, we're hoping to develop something, not necessarily in the DEM file as we're hearing, but maybe in some way a replacement that allows us to be in place and provide regular data. So thank you, Risley. I appreciate it. Breakout group 8.
Some of the topics that we came up with was, number one, administrators don't functionally buy into the idea of documenting DEM files on a regular basis, and this data needs to be uploaded pretty regularly, as well as PPE is actually kind of hard to track when it comes to per incident tracking and in some of the softwares. Another good point that one of our group had was generic data isn't always actionable. If we're not calculating burn rates and applying it to the specific organization, then sometimes this data just is skewed. And there's just an overall thought of, is it really going to benefit organizations to report this data in duplicate places to their state, to their health departments, and then to NHTSA.
Thanks, Keenan. Breakout group number 7. You may be on mute.
Yeah, this is Dan. I can pipe in. I don't think we had anything to outside of what's kind of already been addressed, and we had some of the same concerns. In particular, you know, some of these bullet points maybe are more applicable for the providers and some maybe more for the administrators, but how do you kind of, you know, reconcile those?
Thanks, Dan. Appreciate it. Breakout group 6.
Hi, Clay. Yeah, this is James. I mean, we pretty much agree on everything that's up there. I think the only thing that we would probably add is, you know, with the COVID exposures, this seems to be better placed within the EPCR data, not so much demographic data. You know, and even so, if it is in the EPCR data, it doesn't really give you a true account of the exposures, because the crew members may not even know during that time that they've been exposed to a patient with COVID. They might not have this information for days, you know, or maybe a week later on. So I don't see really how on a national level this would provide any benefit.
Okay, great idea, James. Thank you. Breakout group 4.
Are we skipping 5?
Oh, no, we're not skipping 5. Is that Nate? Sorry about that.
That was Nate. You tried, Clay. I gotcha. All right. Group 5, same as the rest. The two things that we talked about amongst our group that was similar was duplicate data entry, was having agencies having another spot where they're recording this. If it's a different spot in their product currently or using a different product, that would be a pain point. And then it being a real-time question. So like, it seems helpful to track equipment like PPE and stuff like this if it's a real-time thing. So then that can influence deliveries or where more equipment needs to go in the moment. Since DEM file seems like a more infrequent thing, it doesn't seem as helpful in that record. And that's it.
Okay, thanks, Nate. Appreciate it. Group 4.
So Clay, a lot of what we talked about has really been covered before. Just a couple of points, though. You know, in addition to COVID-19, you know, there are other situations like drug shortages that might be able to fall in this. But you know, we're kind of confused about why the DEM file, and it doesn't seem, you know, as real time as other methods. The other thing, you know, I made a comment that it seems like we're mixing patient care and operational data here, and it just didn't make a whole lot of sense to us. Not sure this is really the right way to do it. Perhaps it's something that needs its own data set and another way of transmission. So that's comments from us.
Okay, thank you, Andrew. Appreciate it. Breakout group 3.
Yeah, we're going to echo a lot of what we've already heard. basically, you know, the statement was made, EPCR should not be used as a supply chain database. And each time a change is made, there is a financial impact that's going to be incurred by the state, by the agencies, and by the software vendors and themselves. And again, from the field perspective, the more questions you ask, the less the data integrity would be as well as it should be.
Thank you, Sue. Breakout group number 2.
Yeah, we basically have the same comments as everyone else. It's probably better suited in a different data set. And then it should be a little bit more abstract, not COVID specific. So instead of PPE and COVID, or PPE shortages, medication and equipment shortages instead.
Okay, thank you, Matthew. Appreciate it. Breakout group number 1.
Pretty much a lot of the same stuff, talking about having a different data set scoped differently, not as quick as the PCR, not as slow as the DEM data set. He talked about I think it was mentioned that the hospitals have a different mechanism for requesting PPE, and whether that would be something to either mimic or possibly even tie into. Eric Cheney mentioned several times about trying not to step on the toes of other agencies who are responsible for this. And so we had a slight concern about whether NEMSIS or NHTSA would be the right people to do this even, or if we would be collecting a data set and sending it somewhere besides those two.
Okay, thank you, David. Appreciate that very much. Yeah, so again, thank you for all the comments that were shared. We'll aggregate these again. It clearly sounds like we need to come up with a different solution than suggesting the DEM file. That was an idea that was run by the Office of EMS. I think there's a good consensus here that we need another approach. So we'll aggregate this information, and maybe trying to synthesize another approach will be a good topic on our bi-monthly calls. So if it's okay, Julianne, I'm going to go ahead and take the screen again. Thank you, everyone. That was incredibly helpful. We have one more topic we'd like to cover. We have just a couple minutes less than an hour. But again, an important topic. So grateful to have the vendors here as well as the state data managers to talk about the NEMSIS software compliance policy that was put into place. I'm going to ask Eric if he would be so kind as to co-facilitate with me. But we'd just like to see how this is going, right? It will take effect in some form in January 1st of 2021, where there will be some folks who compliance will fall off for a lack of an ability to meet the compliance standards. So I'm just going to state them real quickly, and then want to talk about what we plan to do with the defined list. We've covered that on a number of the implementation calls, but want to dig into that a little bit. So as it stands now, testing and then retesting needs to be done every 2 years, and that 2-year mark is based on the last successful compliance test date. California is enforcing a within 1 year policy. So rather than 2 years, every year within that last successful compliance test date, they want the software products that are working in the state of California to be tested. We've implemented a policy where participation on the bi-monthly V3 implementation calls, I need a participation greater than 70%. We really had a bump up in the number of people that are participating. I hope they're finding that to be helpful, and we can talk about that a little bit. And then just finally, representation at this annual meeting was part of that compliance policy. I'm gonna stop there for just a couple of quick questions and see if anybody has comments, would like to raise their hand or add a question to the chat. Anyone who feels like they'd like to make a preliminary statement regarding the compliance policy.
Well, I think we're here, so we have less objection to it.
Yeah, Matthew, I see your hand up. Matthew, can you want to go ahead?
Fair.
Yeah.
Yeah, I like the policy. It makes a lot of sense. My only concern has to do with when it comes to recertifying that date. We want to recertify before the 1 year expiration date. That date then gets moved up. So instead of being like 12 months, it ends up being close to like 10 or 11 months. You're going to recertify. Yeah.
Okay, helpful. Monet, were there other hands up, Monet?
Jeremy Laird has his hand up.
I just wanted to chime in and second Matt on that. I think a more beneficial process, if it was possible, would be something along the lines of calendar year as opposed to 12 months since the last time you did it. So you're certified for 2020 rather than, or certifying for 2021. That way you're not just getting this kind of rolling time frame where, last year I did in December, now I got to start it in November, then next year I got to do October just so I meet the deadline.
Sorry, I couldn't get off mute fast enough. And Renee Nelson from Zoll has a question.
Hey guys, just curious, I'm wondering how the NEMSIS TAC is changing their strategy and your resourcing to be able to handle all of this certification. Basically, it's going to be every vendor every year, if they were working in California. So can you talk a little bit about how you guys think you might handle that volume? It's, poor Laurel.
Hi, Renee. This is Laurel. I can answer that question. So the short answer is we've brought on another person to help with compliance testing. Her name is Sujata. She was in the meeting earlier, but I think she had to jump off to do some other work, and she is almost entirely on compliance testing. So there's now more of us that do compliance testing. We also have put in some work to sort of streamline our process and really remove any inefficiencies that existed before. It is a shorter process than it used to be, and there is also less differences between different types of testing to sort of simplify it. We've also been working on improving our CTA application that many folks who've tested with us have seen, where you can upload and compare your files. You can submit your files and then compare them to the gold standard file yourself to correct issues without lots of assistance. But based on what I experienced last year at the end of the year and what we're seeing so far this year, I think that it really won't be a problem for us. Vendor companies have realized that compliance takes some time. I'm seeing people coming for testing earlier this year than they came last year. I still think it will be tight in the month of December, so I would encourage everyone to work on this now. But I don't think that there'll be any real resource limitations on our end. I think we've made the right changes to adapt to that.
That's awesome, Laurel. Just a quick follow-up. You mentioned some changes to process and streamlined procedures and changes. Things are shortened. Is it anything that would impact the vendors or that we should know about, or that you guys will be publishing about those changes?
Yeah, so those are things you've already seen. So for example, our compliance testing process used to heavily involve the pre-test cases and the active test cases. And I'd say the most major change I made was I removed the requirement to enter the pre-test cases. Yes, vendors who are testing should do pre-testing first. It would be helpful for you to use that to work out any kinks. But if you chose not to do that and do active testing only, you only need to enter the 6 active testing cases rather than the 6 active testing and the 6 pre-testing. So I'd say that's the biggest change for vendors, is that pre-testing is now fully optional. And a lot of the reason I did that is vendors testing every year now, they probably don't need to work through a pre-testing stage. If they literally tested, 11 months ago, they're probably already pretty close to compliant.
We have another question from David Saylor at Beyond Lucid, and then Peter from Zoll.
So the topic came up of whether it should be for a whole calendar year, and I kind of lean a little more toward that when I think about it. It's because you have kind of 2 schedules right now, where the V3 call participation, that's per year, correct? Per calendar year?
Yes.
Okay. And so that's kind of a mismatch with your compliance state, where it might be easier for, in general, to have those be the same calendar. And just to kind of, not sure what the best thing to do was, but some of the vendors on the list right now are at 0% participation, so it's mathematically impossible for them to be compliant by the end of the year. So whether that's anything needs to mention that or anything like that.
Thank you, David. That's helpful.
Okay, we have a question from Peter at Zoll.
So yeah, my question kind of comes along with the timeliness of that as well. I am somewhat putting off beginning my compliance testing because I want to be as close to my previous certification date as possible. So that way I don't continue to have to do this earlier and earlier every year, and I'm actually getting my full 12 months. Are there any considerations around that? I don't want to be doing it the last week of December, as I'm sure that the TAC doesn't want me to be doing it, but I also don't want to have to do the compliance testing more often than I have to.
Yeah, good comment, Peter. Thank you.
We have another comment from Keenan at Zoll.
It's a question since all 141 of us are here. Once this mandate sort of gets into action and it is time to sort of revoke the certification of other vendors, is the TAC and NHTSA prepared for the ramifications and sort of what's going to happen after that, as well as the states that some of these vendors are submitting to?
Keenan, this is Eric. That's a good question. I'll answer that one. We have had several discussions on that topic. We've talked to our legal counsel briefly to give them some time to think about it a little bit. And we're not 100% sure what that action is going to be. We have a couple thoughts. I will say that we are scheduling some time to talk with the data managers and with the state directors and medical directors to let them know, hey, look, here's where we are. Here's who would fall into these categories. And as David pointed out, we can tell already who's going to fall out by just attendance on meetings. In some cases, there's no way to get back to compliance by now in the end of the year. And remember, this goes back to a request from the state directors at the August meeting in 2018, right, Clay?
Yes. Yep.
So the idea was, and I believe Texas was one of the leads, and Florida, Steve was another one, that wanted more stringent compliance testing for some of these vendors. That was loud and clear. So we went down that pathway. So in terms of letting the states know, you're absolutely correct. We have to let them know, here's what's going to happen. If we did it today and we said who was compliant, who wasn't compliant, here's who would be on the list, and how does that impact your state? And I think a lot of our actions are going to be driven by their communications. Because like I said, this was a request they made of us. I think it's definitely helped out in terms of participation in some of the calls. I know that in some cases we've had less general questions about things. We certainly feel more confident now telling the stakeholders that we represent that the vendors have heard subject A and subject B, and that no one can say, we have participation lists. We know who, we take attendance. So we know who heard what. We know who got what information. That's been a big help. But you're right. I see the train at the end of the tunnel. So not a definitive answer, but I would say that there have been discussions certainly, and we're working on a solution and an answer to your question in a more direct way.
Thanks, Eric.
All right, other questions right now?
Keenan, just one more thing. I do have to say, I find it interesting. I would have thought going into this, again, not being the software guy or the tech guy, that Laurel would have been the one that weeded people out based on compliance and not just participation on telephone calls. Over.
Yeah, thank you. One other topic related to this compliance policy that I wanted to bring up. Perhaps I can bring it up after the next slide. Any more comments about the policy?
We have a question from Samantha Hedge at ESO.
So I just wanted to say that I wholeheartedly support the participation in the calls in the meetings, because I think it's important as a NEMSIS compliant vendor to communicate and participate in those discussions. I guess my biggest concern is with the NEMSIS tax policy of being compliant or recertifying every 2 years, and then having to come in at a state level every year. It is a resource burden on the vendors to go in and do the compliance testing, just getting all the people together, going and submitting all the test data. If we were going to stick with an annual recertification to stay compliant in California, would it be possible to have, like, I know we've talked about this before, like test cases where for labs and instance, things like that, we're provided some of that information, so we're not wholeheartedly building it from scratch every time, to help facilitate bringing that timeline in.
Oh, got it. Laurel, do you want to speak to that idea? We've discussed that briefly.
Sure. I think we most recently looked at it for the e-device section, having an actual device file that could be imported. And I can't speak to labs directly because I don't know much about that, but I know that for device, we discussed the idea of having a device file from common device manufacturers that we could offer with our test case, in addition to the sort of data that would just fill in the XML like we offer for other elements. And the obstacle we sort of ran into was getting a copy of that test data in those file formats. It was something about working with the manufacturers of those devices where it was hard for us to get the same information in, a multitude of different formats. We did look into it though. We also looked into using the device data set that was developed by the NEMSIS TAC previously, but not adopted by anyone. And of course that was not a solution either, as it was not adopted by anyone. So I guess we're definitely open to suggestions as to how we could better provide some of that data for the test cases that in a normal scenario would be auto-populated from a device or from another system. And for testing, I've tried to be lenient with folks when they say to me, well, I can't change that element. It came out of our CAD system and it just looks like that. I can't put in whatever value you want. But yeah, we're definitely open to hearing how we could improve that process.
Are there other ideas that would streamline the process that folks have? We currently don't want to degrade the value of the approach, but are there other types of efficiencies like that we should potentially consider?
This is Krista from emergency reporting. I didn't know how to raise my hand. I'm sorry. But I just wanted to say that I appreciate you guys being willing to modify or edit some of your testing scenarios. As a full records management system, not only do we have to be NEMSIS compliant, but we also have NFIRS and FEMA, we have IRWIN, and we have multiple other modules that we are managing for our customers, such as a training module, a maintenance module, a messaging module. So I just wanted to say thank you for being willing to modify as needed and to help us out when there are some things that we simply just can't change because of compliance purposes for other modules that we're currently working with. So thank you.
Yeah, thank you, Samantha. Or Krista, sorry. Was there another hand that came up? I thought I saw another hand.
There is another question.
Has her hand. Sorry.
There is another question from Samantha.
Mm-hmm. Would it be possible if a vendor is recertifying in under 24 months that they have a smaller recertification test? maybe 3 scenarios, like we could cut out maybe like the call canceled scenario or something else and just test a smaller number if you're recertifying annually instead of every 2 years. Would that be a consideration?
Yeah, so fewer test cases is basically what you're saying, Samantha. Is that right?
Yeah.
Maybe this is James with CloudPCR. Maybe what if instead of, we just resubmit the test cases and knock off maybe the webinar or something for a California, certification in a way, just a slimmed down version.
So we can't control what California asks for in their compliance test. If California says that they want us to include schematron testing, then the webinar is kind of required because there aren't very many ways to test schematron without having a webinar. And that actually was an issue that came up for them, was proper implementation of schematron. So when California says everyone must recertify each year, it's hard for me to say, okay, well, I'll offer you a slimmed down version of certification. I don't get to decide what California's requirements are.
Right, no, but you get to decide what the NEMSIS tax national certification requirements are. And the policy right now is every 2 years for that. And if we're coming in more frequently than that, could we get a slimmed down test? Could that be the NEMSIS tax national policy? If you're testing annually, it's a smaller test set than if you're testing every 2 years.
Yeah, Samantha, it's a viable idea. We can take that back as an issue to discuss. The test cases, as you know, and I'm sure everybody knows that the test cases are made up to test scenarios that ensure that important attributes of the NEMSIS structure are in place. Is there some ways to slim those down? We can look at that without kind of affecting the quality of the evaluation.
Thanks, Clay. I appreciate that.
Yeah, thanks, Samantha. Yeah, appreciate the comments. Any other ideas regarding the policy? Okay, we're kind of slipping into the other topic we wanted to cover, which speaks to the actual compliance process. And so maybe we can begin just by discussing the changes that were made in relationship to the defined lists. So the work that we've been doing over the course of the summer, kind of defining how we can move the suggested list into a more defined structure. On day 3, we're going to have a really detailed conversation about how this looks. Are we seeing any ill effects yet of the approach? Are there some other processes to put in place? I just wanted to draw your attention to the fact that we have updated both the NEMSIS version 3 compliance policy and the NEMSIS version 3.5.0 compliance process for collect data software to include sections that talk about the defined list needs to be there. And Tim, if you'd be so kind, if you would list those locations in the chat, that could be helpful for folks. Another important piece of this testing that we actually developed just based on the vendors, who allowed us to view how you're having your providers populate elements like symptoms or primary and secondary impressions. Thank you so much for doing that. That was incredibly helpful. We have devised just another section to the web conference where Laurel and Sujata will basically just at a high level review to ensure that all items in the defined list are appropriately implemented for those elements that utilize ANSI standards. And so the interface would show those defined lists. That's That's the idea behind the compliance testing. I think I saw Doug's hand up. Doug?
Yeah, thanks, Clay. I just want to clarify this. I know we're going to talk about this on Friday. The defined list, according to this, must be all active for the 3.5 compliance. Is that correct?
Yes.
So, and Clay, we emailed. I know that you were waiting to respond back to our email. We're getting a lot of concerns off of these lists. I'm just concerned that we haven't vetted this through a medical directors committee or outside. I know that you're getting people's feedback. We've been holding off our feedback until we got our response from you, because we are getting a lot of feedback from clients and state administrators that are concerned that these values are missing gaps. So I know we're going to talk about it on Friday. I'm just concerned that it seems like we're moving really quickly on this defined list without vetting it. And I don't know if anyone else feels that way a little.
Yeah, Doug, would love to hear from other people, but yeah, thank you. Other vendors or states would like to comment on that idea that Doug shared?
Doug, this is Eric. So this is where I need a little specificity. So I don't need the who as far as reporting it, but what groups should see this? And this is where, when I took over this project, honestly, I thought there would be a roadmap for some things given the years that it's been in place, but there's not. So when certain things come up, I'm often asking Clay, okay, who needs to see this? Or I'll go to Dr. Kramer and say, all right, here's what we're planning on doing. Who needs to take a look at this? And I need, so obviously NEMSIS's medical directors group would be one. Are there others?
Yeah, I would encourage the metrics. So like the National EMS Quality Alliance, because some of these defined lists actually are eliminating some of their current elements that they are nationally reporting off of. So when we kind of toss this into our reporting matrix and I kind of compared what effect does this have to our pre-can reports and all these other organizations that we partner with, the National EMS Quality Alliance was one. California's core metrics, I know Mark's on the call, I believe. Some of these elements are actually that are listed in their matrix document would not fall under these defined lists. So before we kind of move forward, I just want to make sure we either work with these other groups or we work on vendors and how we can modify this reporting standards for those kind of groups.
Okay, I hear you loud and clear. But so let me ask another question, and this will show my ignorance. If in doing this, I saw the work behind what the TAC did to determine what elements basically stayed or went, for lack of a better term. And the ones that went represented such a very small segment of the population or of calls or events, yet we seem to have metrics built on them. I don't, that's a little confusing to me.
Yeah, we were, the document that was sent out showed 212 primary impressions. Our data alone, I can tell you right now, we have 800 plus primary impressions, different ones. So we're confused about some of these values because we know we're sending more than 212 different primary impressions to NEMSIS. And I do agree, these lists are crazy, they're long, they need to be vetted. But we're seeing things that are more commonly used on the image trend systems that aren't showing up on the data that we're looking at these spreadsheets. And I could save this conversation for Friday, and I don't mean to derail this. It's just we're seeing some challenges here, and I think there's other areas we can optimize. Just our data doesn't match what we're seeing from NEMSIS, and that's kind of what we're working with some of our state clients and large clients across the nation, saying, okay, these are the defined lists. Do you have any recommendations? And we kind of reached out to everyone, and we're seeing some conflicting information. So we're trying to figure out why don't those numbers match.
Good to know. Thank you. And Amber just sent a note based on my comment, and she's right. Just because it's a small number doesn't mean it's clinically irrelevant. And you're right. I guess that's what I'm wrestling with. I'm having the same kind of questions about the DEM files too, but we'll come back to that at another point. I'm trying to find a slide to show you one day, probably Thursday, on why some of the data is being collected. I think that might help with some of the discussion on the previous question in the previous breakout room. Over.
Yeah, Doug, and this is Clay. Maybe just one clarifying thought. This is a great comment. Thank you. And this will maybe help prepare us for Thursday as well. So, for example, with the National Quality Alliance, was the issue, Doug, and I appreciate you having this specific example, was the problem that the code that NEMSIS was suggesting wasn't the same code that's being used by the National Quality Alliance or by California's quality measures, or was it that really the topic, that the issue, the symptom or sign wasn't included on the list?
It's the code. Right? The value is intense there. It's just the problem is and Clay, the question was, are we rolling them up? Is NEMSIS rolling it up? I don't want to put a defined list out to our clients and say, here's this. Oh, by the way, all of our CAN reports for national reporting doesn't work that we partner with, or is the expectation that we'll roll those codes up as a vendor, and then we just want to let those organizations know, hey, we manipulated this data before sending you that. I think it's possible. I just want to be transparent. And I think anytime that you're rolling up a code or you're manipulating the data, you have that, it just becomes that. It becomes manipulated data. So we just wanted some clarifying questions about that. And I'm all for moving forward with lists. I just want to make sure we vet them through all these organizations as well. I don't want to slow down the process, but I can see some challenges with organizations that are collecting national EMS benchmarks across the country.
Okay, thank you, Doug. Appreciate that. Yeah, that'll be helpful for Thursday. Thank you.
There's a question from Frank Sloan with R1.
Sure. Yeah, I was just going to comment quickly on this topic. Our understanding was the defined list would be the default in the software, that there's no change to the actual codes that can be sent, and that all the roll-up would be done by NEMSIS. If what I said isn't true, then we have concerns in this area as well.
Yeah, no, that's true.
Okay. Perfect. Thank you.
Yep. Any other questions related related to this new compliance policy? Okay, great. Thank you. That's very, very helpful. I wanted to cover one more topic just real quickly related to the compliance process. The web conference section of the testing process is becoming more valuable, right? So here, the way that we're going to be evaluating the presence of these defined lists, and we'll get into the limitations and other pieces associated with this policy, but the way that we'll be testing that will be through the web conference session where we'll actually be online. I wanted to ask among the vendors and among the states if there were any other attributes of a software product that we may want to evaluate during this web conference section. The vendors that are in that process now recognize what we look at, what we've looked at in the past, how it's extended now. I just wanted to put a thought out there and see if anybody had any comments related to that process. Are there other things that we should be looking at? Is there a better way to do that session? I think we found it to be incredibly valuable. Any other comments?
We have a question from Ryan Smith at R1.
Hi. So we've been going through 3.4 recertification. We also went through the 3.5 receive and process certification. And I just got to say, you guys are doing a great job with the certification process. The one comment that I had, and maybe this is more of a lack of direction or a lack of documentation somewhere, but we found that with the custom elements that were being tested on, some of the parts of custom configuration section are a little ambiguous. And I know I've brought this up to Laurel during our certification, but and we worked through that and everything, but I just feel like each time that we went for certification, we took the custom elements that were part of the test case, we implemented them in our system, but then we always had to tweak something because maybe we do something slightly different than what the TAC does. But again, some of those elements just have a bit of ambiguity in them. It would be nice if there was either a bit more, I don't want to say make it more strict, but like kind of just define the intent of some of the elements. And Laura, if you have any comments, I know I've mentioned this to you before.
I don't really have any comments. That's something that we're looking into based on the issues that came up when we were testing you. So whenever, for everyone on the call, whenever we do go through compliance testing and there is an issue that comes up in testing and we have to make a change or we ask you to make a change and it wasn't clear, we do take those comments back and try and either make our documentation more clear, make our process more clear, or correct any errors or bugs in test cases or implement any suggestions in future test cases.
All right,
Yeah, Ryan,
that's all I had. Thank you.
Yeah, thanks, Ryan. That's a really good comment. We're aware of that. That's an area that we could work on as well. Yeah, thank you. Other comments? Okay, great. There's really been some great ideas shared during this section. Thank you very much. I very much appreciate your feedback regarding the compliance process. This is incredibly helpful. Yeah, so thank you. We are getting close to wrapping up. I did want to ensure that we had a little bit of time. I'm gonna see if I can go back here a couple slides. I apologize. Let me just move through these quickly. Wanted to spend just a couple of quick minutes before we wrap up here talking about the agenda for Wednesday and Thursday. Wednesday is going to be a very busy day where we talk a little bit about some of the work we've been doing to provide some helps with facilitating bidirectional data exchange. We'll start the day with that. We want to concentrate on what we can provide and continue to help with the rollout of version 3.5.0. We'd like to provide whatever we can to really help agencies and states and vendors with this rollout process, hopefully improving our ability to make that change without some of the angst we've experienced in the past, if there's things we can do to help with that. So maybe you can be thinking about that a little bit. Then really the second half of the meeting is really pretty intense, where we're hoping to just have two major breakout rooms. One where we have primarily vendors who will help us work on some products in this next funding year that will help with bidirectional data flow of EMS data between HIEs and hospitals. So we have, as Eric mentioned, they've done a great job of providing some funding for us to provide some overall tools that can help you ensure that exchange happens. So we'll both be talking about kind of the political barriers and then maybe some of the technical barriers as well. While the vendors are talking about that, the state representatives will be breaking off to talk about an NEMSIS resolution that we're proposing to be presented before NEMSIS leadership in October during their annual meeting. releasing geographic data at the national level. So they'll break off to cover that that session. And then we'll both come together because I think the states are going to be very interested to hear the report out in regards to what we plan to do in regards to the development of products or implementation guides to help facilitate bidirectional EMS data flow. So that's the story for Wednesday. As I mentioned on Thursday, we're gonna really dig into ET3. We're going to talk about migrating suggested list to defined list. So some of the things that Doug talked about, others talked about, we'll dig into that deeper. And then we want to talk a little bit about the submission lag we're kind of seeing in the data that's coming to the NEMSIS TAC. This has never, of course, been an issue in the past, but now with these requests federally for kind of real-time surveillance and either through ODMAP or biospatial, all these different processes that are really trying to provide more surveillance type reporting. Maybe we can talk a little bit about the barriers or solutions that we could come with that might help both politically and technically to have the data flow more quickly. That's what we have in place right now. I wanted to take just a moment and ask if folks feel like there's other burning questions that we need to make sure we cover in the next 2 sessions that aren't listed here, but could be incredibly valuable for us to discuss. So I'll stop there and see if there's any comments.
We have a question in the chat from Juan Esparza in Florida. Will you reject files from vendors that lose compliance?
Oh, yeah, thank you, Juan. I apologize. We may have jumped off that topic a little quickly. I think I'm going to reserve the comment on that. I'm fairly confident that you're correct, but I know that the policy is under review in Eric's office, in the Office of EMS at NHTSA. So I think I'll hold judgment on a final comment. Would you agree, Eric?
Yes, Juan, I would tell you that before that would ever happen, you would have months of notice.
Thank you.
Right, thank you. Yeah, Doug, I see a comment from you. You're always one to remind us that we need to speak to the leadership in EMS offices. Do you want to expound on that a little bit, Doug?
Yes. In a state that whose state director is not one to put up with a solid definition from NEMSIS, because he's still going to direct his state in the way he wants the things to go and needs to go for the good of the state of Nebraska. So I think there are other, at least we as data managers have run into buzzsaws in the past when a lot of different things hadn't gone to the state directors for their implementation and approval. And particularly, I'm going to point back to the defined lists. So if all of these things are moving forward without any perusal by the state directors, all on their own, separate from everybody else, except for Eric and the good doctor, there's very, very short time for that to happen in. So if there are state directors listening to this conversation, you better be speaking up. And Eric and you guys above probably should be reaching back to the state directors to say 3.5 is real, and here are the final things that are coming.
Yeah, thank you. I agree. I told you, earlier today that I had a conversation with Dia, because my understanding was that when we were working through the state data managers, that information was going back to the state directors, and that's when she corrected me and informed me that that wasn't accurate. So that was wrong on my part. So the lead in, the next part of that conversation was, okay, so how do we take things to the state directors and what things go to the state directors? That part is still a little fuzzy. We're working that out. Our first step was this monthly report that has projects like this listed on it. The second phase is, do I need a 15-minute forum when the state directors meet with the SEMSO just to give them an update on data projects or NEMSIS projects, and have them tell me, yes, they would like to weigh in, or no, they would not like to weigh in. That's still a little confusing part for me. We deal with a lot of questions that have impact on ET3, and I have worked with the ET3 team to try to get time and put them in front of the state EMS directors, whether that's NEMSIS, the directors at a separate meeting. Certainly, we've gotten them to the data managers meeting. We invite them. So we have them at NEMSAC, we have them at FICOMS. That's an example of where we've tried to pull in some of these efforts. So I hear you loud and clear, and I'm working with them to try to move that process along, but I'm still a little fuzzy on what needs state director blessing, what doesn't, what they're truly interested in, and what they're not interested in. So, you know, if you have feedback, if you hear something that needs to go to the state directors, by all means, let me know. If these lists need to go to them, that's interesting. Or are they going to say the medical directors review them, and if the medical directors are good with them, we're good with them? And then my other question is, like, what happens if the medical directors are say that we want to expand this out to 800, and the data managers say, you know, for all the reasons we worked on this should only be 250? Who ultimately trumps who in some of these questions? And I can see the conflict, but that doesn't mean I won't try. It doesn't mean I won't take it to all three of them. I'm just pointing out that there's no clear definitive approval path for some of the things that we look at. Over.
Thank you.
Thank you, Doug. Other state data managers want to share comments related to that topic?
And you see, this is the pinch that we are in, the state data, not managers, but you know, we work for the director, we're managers type of thing. And until we get back together with our state directors, there's could be up to another month that goes by. And next thing you know, we're right on top of rolling things out. And I just don't want to go through the hell that we went through about 2 years ago. You remember all of that, Clay, as well as I do, and everybody else that's been around since then, that unless they are talked to, then they indeed feel as if they have not been part of the discussion.
Yeah, it's interesting, because we talked about some of the ways to send them information, and all that is basically managed through for our office through NEMSIS. So I hear you loud and clear. I kind of feel like I'm in the same position. In one hand, we're trying to move things forward. On the other hand, I'm budgeting to move things even further forward on assumptions that this is where things are going to go. This is how things are going to happen. So I feel the pain, and I ask Clay, we've done everything we can possibly do to be as open and transparent about all the projects that we're working on and get that information out there. So what it sounds like to me is that I need to be even more aggressive, and I can promise you I will do that.
Well, in my opinion, just pardon my French, but keep your butt covered, Eric. You just don't know what you're going to run into when we probably won't have face-to-face NIMSIMSO meetings. They're going to be meetings like this, and I don't know where the directors are going to go. I really do not know. I just know on this side, Tim, my boss, is obligated to defend and take care of the state of Nebraska, and NEMSIS and everything else comes second because of dollars, because of politics, because of all kinds of different things that they get themselves in. So
yeah, it's interesting, and I really I got to find a couple slides for y'all for Thursday, and I'll do that because it's looking at this from a great big overview. We have 138 people in the line with probably 170 different opinions, and that's wonderful. Trying to find that middle ground and trying to find where to go that's going to be the best for everybody is the challenge. And then the real challenge is who is everybody. And I'll go back to what I said earlier when Dr. Kramer was on the line, and he and I have had this discussion many times. It's got to benefit the clinician, it's got to benefit the patient, it's got to benefit the community. But I realize there's a cost involved in all that. I realize that there's time involved in all of that, that we can't change directions overnight. And to make all that happen takes approvals. And that's where you're at right now. And whose approval does it need? In your case, in your state, it's very clear. In other states, it's maybe part of the Department of Health. It's maybe a little bit more wishy-washy. I'm still learning the lay of that land. And thanks to people like Monet, who work with the states a lot more than I do and has worked with him a lot longer than I have, I get a little bit better information. So any advice that anyone has for me like that, I really appreciate it. But I will certainly make sure that all the topics of any kind of importance coming out of this meeting get briefed out or at least written out and distributed to the leadership of the state directors. Truly.
thank you for your guidance.
Yeah, thank you, Doug. And this is a great primer for tomorrow as well, right? When we're kind of talking about the rollout of 3.5, it'll be important for Eric and I to understand this and other ways that we can be much more proactive and much more kind of pushing things out instead of making things available for people to pull. Perhaps that could be helpful. I'll just acknowledge we've had some great comments in the chat. We haven't picked up all those in the conversation. I apologize for that. This is our first attempt to do a giant webinar like this. We've learned some important things, including that I can't count backwards, and some other important things. We'll try to fix those things for Wednesday and Thursday. Want to call the question one more time. I just briefly, are there any other topics that folks want to mention that we should ensure we make time on either Wednesday or Thursday to discuss? Are there other topics that folks can think of that we should incorporate into the schedule? Okay, hearing none, folks may feel like we're covering the major things. Hopefully that's true. Tomorrow will be very, very busy. We look forward to your comments. I think there are passionate topics on both Wednesday and Thursday. I appreciate your willingness to form yourselves into groups and to make such good use of that time in providing us such rich information regarding the questions that we had. We'll be doing the same approaches on Wednesday and Thursday, and hopefully we can continue to collect some valuable information that will vet over the next funding year and produce products and make changes based on what we're learning. So this has been incredibly valuable. All the opinions that have been shared, we appreciate it. All the comments we're keeping track of, and we'll make those available to the TAC and to Eric's office after the meeting is over. Are there any more items that folks would like to discuss before we drop off the call? You just might get 5 minutes of your day back. Any comments about the structure, the way that we are attempting to hold this meeting? As I mentioned, this is our first attempt at this. Are there other attributes of what we're doing that we could improve? Other than not having my Outlook memo show up on the screen? All right, folks. Well, thank you very much for spending your 4 hours with us today. This has been incredibly helpful. I hope that you're finding it helpful as well. We'll look forward to seeing you tomorrow again at the same time. We'll start at 9 a.m. Mountain Time, and look forward to you being back with us and sharing more of your insights with us. Thank you again for being with us.